You know, there's a specific kind of irony in the fact that the human brain is the only object in the known universe that has named itself. It's the processor for every sensation you have ever felt. Love, heat, hunger, and certainly pain. It's the seat of
It's
consciousness.
the command center for everything we are, absolutely.
Right. But here is the paradox that completely stopped me in my tracks while we were prepping for this deep dive. The brain itself, the actual gray matter, the parenchyma that is doing all this complex processing, is completely numb. It feels absolutely nothing.
It's true. It's one of the great anatomical curiosities. You could be wide awake on an operating table, and a neurosurgeon can cut into your brain tissue or cauterize a specific area, and you wouldn't feel a thing.
Not a
No
thing.
anesthesia is required for the brain itself because it simply doesn't have the receptors for it. It's wild.
Which begs the immediate question we're tackling today. If the brain can't feel pain, why does a headache feel like someone is taking a power drill to my temple? Or, like my skull is in a vise.
Because while the processor is numb, the wiring and the packaging are incredibly sensitive. We aren't dealing with pain in the brain. We're dealing with pain in the structures that keep the brain alive and protected.
So when we talk about the packaging, we're talking about the duramater, right? That tough, leather-like sac that holds the brain.
Exactly that. The duramater is just loaded with pain receptors, and then you have the wiring, the large intracranial vessels, the arteries and veins that sit at the base of the brain. When those vessels stretch or dilate or get inflamed, they trigger the alarm system.
And that alarm system is the trigeminal nerve. This kept coming up in the research. It feels like the central villain of our story today.
Or the overzealous security guard, depending on your perspective. The trigeminal system is responsible for sensation in your face and head. It has three main branches that cover your forehead, your cheek, and your jaw. So when the blood vessels inside your skull expand, say during a migraine attack, they physically irritate the nerve endings wrapped all around them. The trigeminal nerve screams damage and shoots a signal down to the brainstem.
And the brainstem relays that to the thalamus. The thalamus then yells at the cortex, and suddenly you're canceling your dinner plans and looking for the ibuprofen. So really, a headache is a proximity alarm. It's the casing of the computer overheating, not the chip itself.
That is a perfect way to visualize it. And because that alarm system is so primitive and so loud, it can be triggered by almost anything. Dehydration, stress, wine, lack of sleep, or a tumor.
Which brings us to the core mission of this deep dive. Because the alarm sounds somewhat similar, whether it's just a stress or something catastrophic, we need to learn how to distinguish between a false alarm and a five-alarm fire.
That's the distinction between primary and secondary headaches. That is the fundamental divide in neurology. A primary headache means the headache is the disease. A secondary headache means the headache is just a symptom of something else, possibly something lethal going wrong in the body.
And we are going to start with the scary stuff, the secondary headaches. The lecture we analyzed calls these the red flags. This is when the headache is a symptom of a tank about to run you over.
Correct. And while the vast majority of headaches are benign, the secondary ones are emergencies. Clinical evaluation is entirely focused on ruling these out first. You don't want to diagnose someone with a migraine if they're actually having a brain hemorrhage.
So to help with this, the medical community uses a mnemonic that I actually found really useful rather than just catchy. SNOOP. It's a checklist for when you should panic, or at least when you should go to the ER.
It's the standard framework. I mean, if a patient walks into a clinic, the neurologist is running SNOP in the back of their mind before the patient even finishes their first sentence.
So let's break it down, because I think everyone listening should have this in their mental toolkit. The S stands for systemic. This feels intuitive to me if my head hurts, but I'm also running a high fever or I've lost 20 pounds in a month. I'm not thinking tension headache.
You shouldn't be. No. You should be thinking infection or malignancy. If you have a headache combined with a fever, you absolutely have to rule out meningitis.
Meningitis was the first nightmare scenario in our stack, and the literature mentioned a specific physical sign called neutral rigidity.
Right. And we need to be clear on what that is, because people wake up with stiff necks from sleeping on a bad pillow all the time. That's not what we're talking about.
It's not just a sore neck.
No. Neutral rigidity is mechanical. It means that inflammation in the meninges, that packaging we talked about, is so severe that the muscles lock up to protect the spinal cord.
So it's not just, ow, my neck is tight. It's my neck is fused.
Exactly. The classic test is trying to touch your chin to your chest. If you have meningitis, That movement stretches the inflamed meninges, and your body will physically stop you from doing it. It's agonizing. If you physically cannot touch your chin to your chest, that is an immediate emergency.
Okay, so that's S, systemic symptoms like fever or weight loss. Then we have N, which stands for neurological signs.
This is where the headache comes with baggage. Confusion, weakness on one side of the body, difficulty speaking, or changing consciousness. Anything that points to the brain itself not working properly.
Basically, if the headache is messing with your ability to function as a human being, walking, talking, thinking, it's a red flag.
Precisely. A standard headache, even a severe migraine, shouldn't rob you of your motor skills. If the hardware is failing, if you can't lift your left arm, the headache is secondary to structural damage. You're looking for a tumor, a stroke, an abscess. Something serious.
Then we hit the double O's, onset and onset age. Let's look at onset first. This specifically refers to the speed of the headache, doesn't it?
It does. We call this the thunderclap headache. And the defining feature is the timeline. Most headaches, even the really bad ones, have a ramp-up period. You feel it coming. It builds over 20 minutes or an hour. A thunderclap headache hits maximum intensity. We're talking 10 out of 10 agony in under 60 seconds.
1 minute you're fine, the next minute you're on the floor screaming.
Literally.
Yeah.
Patients describe it as being kicked in the head by a horse or hit with a baseball bat. It is explosive. And it usually signals a subarachnoid hemorrhage.
Which is a ruptured aneurysm.
Right. A blood vessel in the brain has a weak spot, it balloons out, and then it bursts, filling the space around the brain with blood under high pressure. That chemical irritation from the blood causes immediate blinding pain.
And the research mentions something called a sentinel headache in relation to this, that sometimes you get a warning shot.
Yes, and this is why taking a patient's history is so vital. Sometimes a patient will have a smaller but still very sudden headache a few days or weeks before the big event. That might be a sentinel leak, a tiny amount of blood escaping the aneurysm before the catastrophic rupture.
So it's a warning.
It's a huge warning. That's why we take sudden onset so seriously.
Yeah.
If you tell a doctor it was the worst pain of my life and it went from 0 to 100 instantly, you are getting a CT scan.
Yeah.
There's no debate.
Okay, that's the first O. The second O is onset age.
This is a demographic flag.
Yeah.
Primary headaches like migraines usually start young teens or 20s. If a patient is over 50 and suddenly develops a brand new type of headache they've never had before in their life, we are suspicious.
It's the guilty until proven innocent rule?
Exactly. A new headache in a 60-year-old is not a migraine until we prove it's not a tumor, or something called giant cell arteritis.
Giant cell arteritis, or temporal arteritis, was another one of those specific nightmares in the file. And the stakes here are incredibly high regarding vision, aren't they?
They are. This is an inflammation of the arteries, specifically the temporal artery on the side of the head. It typically affects that onset age over 50 group. The artery itself might feel thick or tender like a cord under the skin.
But the symptom that really stood out to me was jaw claudication. That just sounds painful.
It's a classic sign.
Yeah.
Claudication essentially means muscle pain due to lack of blood flow. So the patient starts chewing a piece of steak or, some gum, and their jaw muscles start to cramp and hurt because the inflamed arteries can't supply enough oxygenated blood.
And if you ignore that jaw pain,
you risk sudden, irreversible blindness. The inflammation can travel up to the ophthalmic artery and choke off the blood supply to the optic nerve. It's like a stroke in the eye. Once that vision is gone, it doesn't come back.
wow.
That's why if we even suspect this, we start high-dose steroids immediately to reduce the inflammation.
Yeah.
We don't even wait for the biopsy results. It's that urgent.
It's terrifying how connected it all is. Jaw pain leads to blindness. Okay, the last letter in SOOP is P for pattern change.
This applies to people who already have headaches. If you've had migraines for 30 years, you know what your migraine feels like. You know its personality. But if suddenly the pattern changes, it becomes progressive, it never goes away, or the character of the pain shifts dramatically, that's a red flag. You can't just assume it's the usual if it doesn't act like the usual.
Before we leave the red flags, I want to touch on brain tumors briefly. I feel like this is the #1 fear people have. If I have a headache, my brain immediately goes to, it's a tumor.
It's the kindergarten cop effect.
Yeah.
It's not a tumor. And statistically, it usually isn't. In fact, our sources said only about 30% of brain tumor patients present with a headache as their initial symptom.
Only 30%.
Yeah. Seizures or cognitive changes are actually more common first signs.
But when it is a tumor headache, it has a specific mechanical personality. It's not usually a sharp pain.
No,
Yeah.
it's typically dull, steady, and deep. But here's the key. It often gets worse with posture changes. Bending over to tie your shoes, coughing, or straining on the toilet.
Why does bending over make it worse? What's the mechanism there?
It's all about volume and pressure. The skull is a closed box. It has a fixed amount of space. If you grow a tumor in there, you're taking up spare room. When you bend over or strain, you naturally increase the pressure inside your head, the intracranial pressure. If there's already a mass taking up space, that extra pressure spike stretches the dura and causes pain.
And the morning headache is a classic sign too, right? That you wake up with it.
Yes, because when you sleep lying flat, cerebrospinal fluid and blood volume in the head increase slightly because gravity isn't draining it away. If you have a mass, that slight overnight pressure buildup means you wake up with a headache that gets better after you've been upright for an hour or so.
That makes so much sense mechanically. Okay, we've covered the tanks, the things that can kill you. Now let's pivot to the primary headaches. The vast majority of what people actually suffer from, the lecture calls them the big two: migraine and tension.
And we have to start with migraine. And I think we need to dispel a myth right off the bat. A migraine is not just a bad headache.
No, it's a full-body neurological event. It's a storm.
It is. It's a complex disorder of sensory processing. And just like we had SNOP for red flags, we have a mnemonic for diagnosing migraine. P&A. P-O-U-N-D. To be confident it's a migraine, usually you need 4 out of these 5 features.
Okay, let's run through PND. PNA is for pulsatile.
The pain throbs. It has a heartbeat. That's the blood vessels dilating and pulsating against the sensitive trigeminal nerve endings.
APA is for 1 day duration, roughly.
The guideline is 4 to 72 hours. If it lasts 10 minutes, it's not a migraine. If it lasts a week continuously, it might be something else or a complication. It has a specific window of misery.
U is for unilateral.
One-sided. This is a classic hallmark. It loves to settle behind one eye or on one temple, though it can shift sides from one attack to the next.
N is for nausea.
Migraine is almost always a sick headache. Nausea and vomiting are central to the diagnosis because the brainstem centers that control vomiting are right next to the pain centers being activated. They get caught in the crossfire.
And D is for disabling.
You can't work. You can't drive. You want to lie down in a dark, quiet room. If you can push through it and go to the gym, it's probably not a migraine.
So that's the diagnosis. But what really fascinated me in the deep dive was the breakdown of the phases. I always focused on the pain phase, but the storm starts way before that.
It does. There's the premonitory phase or prodrome. This can happen hours or even a day or two before the pain hits. And the symptoms are bizarrely varied. Patients might experience mood changes, euphoria, or depression, uncontrollable yawning, or specific food cravings.
That one blew my mind. The craving for chocolate. People think I ate chocolate and then I got a migraine, so chocolate is my trigger.
Exactly. But causally, that's completely backwards. The craving for sweet or salty foods was the first symptom of the migraine starting in the hypothalamus part of the brain. You ate the chocolate because the migraine had already started.
Right.
Then the pain hit and you blamed the chocolate.
Talk about being framed.
Right. Then for about 20–30% of patients comes the aura. This is a wave of electrical depression moving across the cortex of the brain. It's usually visual flashing lights, zigzag lines, or a spreading blind spot. It's like watching an electrical storm move across the radar of your brain.
And then the headache hits. And finally, the postdrome, the hangover.
The migraine hangover. Even after the pain is gone, patients feel washed out, exhausted, or have brain fog for another 24 hours. The storm has passed, but the city is flooded. The whole event, from start to finish, can be a 3-day ordeal.
Biologically, what is happening during the storm? The text got pretty dense here, talking about monoaminergic sensory control systems. Can we translate that for everyone?
Think of the brainstem as having a volume knob for the world. Usually it keeps the volume at a comfortable level, say a 5. During a migraine, something goes wrong with the neurotransmitters, serotonin, dopamine, and a protein called CGRP, and the volume now gets ripped off and cranked to 11.
So normal light becomes blinding.
Yes, that's photophobia. Normal sound becomes deafening. Phonophobia. Even the gentle pulse of your own blood becomes an agonizing throb. The brain has lost the ability to filter sensory input. Everything is too loud, too bright, too much.
Now, regarding treatment, we've had triptans for a long time. They're the standard abortive. But the landscape is changing, right?
It is, dramatically. Triptans like sumatriptan work by constricting those dilated blood vessels. They are very effective for many, but because they constrict vessels everywhere, they can be risky for people with a history of heart conditions or high blood pressure.
But now we have the gepants.
Yes, the CGRP antagonists. CGRP is a key protein that transmits pain signals during a migraine. The gepants like Obrelvy or Nurtec block the receptor for that protein. They stop the pain message without constricting the blood vessels.
So it's much more targeted.
It's a much more targeted, elegant solution, especially for patients who can't take triptans. It's a huge step forward.
It's amazing to see the science evolve from take an aspirin to let's block this specific neuropeptide receptor. Now, let's pivot to the other member of the big two, the tension-type headache.
The featureless headache, as neurologists sometimes call it.
That sounds almost insulting. Your headache is boring.
In a diagnostic sense, it is. And that's not a bad thing. It's defined by what it lacks. It usually has no nausea, no vomiting, and it isn't made worse by routine physical activity. You can walk around with a tension headache. You might be grumpy, but you can function.
And the sensation is different. It's not the throbbing pulse of a migraine.
No. Patients describe it as a band-like pressure, like a tight hat or a vice grip squeezing the temples. It's usually bilateral on both sides of the head at the same time.
The mechanism here seems to be a mix of physical and neurological issues.
It's a combination of peripheral muscle tension, literally tight muscles in the neck and scalp from stress or bad posture, and a lower pain threshold in the central nervous system. The volume knob isn't at 11 like a migraine, maybe it's just at a 7, but the muscles are screaming into the microphone.
And for most people, this is an annoyance. You take Tylenol, you drink water, it goes away. But for some, it becomes chronic.
Yes, if it's happening 15 days a month or more, simple painkillers aren't enough and can actually make it worse. We often use low-dose antidepressants like amitriptyline, not for depression, but because they help reset that pain modulation system in the brain.
Okay, we've covered the dangerous tanks and the common bicycles. Now we are entering what I think is the most visceral section of the lecture, the suicide headaches. Or, technically, the trigeminal autonomic cephalalgias.
It's a very sterile name for a horrific experience. These headaches are distinct because they combine severe, strictly one-sided pain with autonomic symptoms on the exact same side.
What do you mean by autonomic symptoms?
It means your eye turns bloodshot red, it tears up uncontrollably, your nose runs or gets stuffy, or your eyelid droops. Your face literally reacts to the pain on that one side.
The most famous or infamous of these is the cluster headache. And the profile here is quite different from migraine.
Very, very different. While migraines are 3 times more common in women, cluster headaches are historically much more common in men, though that gap is closing. But the key difference is the patient's behavior during an attack.
I was struck by this description. When I have a migraine, I want to be a statue. I don't want to move a muscle.
Correct. You seek stillness. But a cluster patient is agitated. The pain is so sharp, so piercing, usually right behind one eye, described like a hot poker, that they cannot sit still. They pace the room, they rock back and forth, some bang their head against the wall or the floor. They're literally trying to outrun the pain.
And the name cluster refers to the timing.
It's clockwork. Patients have these cluster periods. They might go a year, 2 years with zero pain at all. Then suddenly a cycle starts. For 6 weeks, they will get attacked every single day, and often at the exact same time.
The lecture mentioned alarm clock regularity.
Yes, a patient might wake up at 2:15 a.m. every single night screaming in pain. The attack lasts anywhere from 15 minutes to 3 hours, and then vanishes as quickly as it came until the next day.
And during that cluster period, alcohol is a massive trigger.
It's like a light switch. If you are in a cluster cycle, even a sip of wine or beer will trigger an attack almost instantly. But if you're out of the cycle, in remission, you can drink socially with no problem at all.
Which brings us to the treatment. And this is my favorite fact from this entire deep dive because it feels so analog. The cure for this complex neurological storm isn't a synthetic opioid, it's air.
High-flow oxygen. It is remarkably effective. You put a non-rebreather mask on the patient, crank it up to 12 or 15 liters per minute of 100% oxygen, and for a majority of patients, the pain simply evaporates in about 15 minutes.
Do we know why? Is it just flooding the brain?
We believe it causes profound vasoconstriction, clamping down those dilated vessels pressing on the nerve, and it also seems to inhibit the pain pathway in the brainstem. But clinically, it's like magic. The only downside is you can't carry an oxygen tank in your pocket.
Now, things get really like a detective novel. We have a couple of other headaches in this family that look like cluster headaches, one-sided severe red eye, but they aren't. And the way you tell them apart is by giving the patient a specific drug.
This is the endomedicine responsive group. This is pure medical detective work. Take paroxysmal hemicrania. It's similar to cluster, but the attacks are shorter, 2 to 30 minutes, and happen much more frequently, maybe 20 to 40 times a day.
Imagine having a drill in your eye 40 times a day.
It's debilitating. But here's the kicker. If you give this patient the drug indomethacin, which is just an older, strong NSAID, the headaches stop completely. Absolute remission.
So the drug is the diagnostic test.
Exactly. It's pathognomonic. If
Okay.
indomethacin works, it confirms the diagnosis. If it doesn't work, it's not paroxysmal hemicrania. It is a binary switch.
And there's another one that responds to this.
Yes, hemicrania continua. This is a continuous, one-sided headache that never fully goes away but has spikes of severe pain, along with those autonomic features. It also responds absolutely to indomethacin. So if a patient has a strictly one-sided headache that never goes away, trying this drug is a mandatory step. It's the key that unlocks the diagnosis.
But then we have the one that indomethacin doesn't fix, the one with the sawtooth pattern, SONCT and ASUNA.
SONCT stands for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing.
That is a mouthful. Let's stick to SUNCT.
Sounds good. These attacks are ultra-short, seconds, maybe a minute, but they can happen up to 200 times a day. The pattern on a pain chart looks like the teeth of a saw, just rapid-fire pain spikes over and over and over.
And the triggers are weirdly specific, almost like trigeminal neuralgia.
Yes, touching the face, chewing, brushing teeth, even a breeze hitting the face can set it off. But unlike trigeminal neuralgia, you get the red eye and the tearing. And, crucial for the listeners, indomethacin does not work here.
So if you misdiagnose this as paroxysmal hemicrania, the patient suffers.
Correct. The treatment of choice here is lamotrigine, which is an anti-seizure medication. It calms the nerve firing. It really highlights why I have a headache isn't enough information. The difference between indomethacin and lamotrigine is the difference between relief and agony. And you only know which one to pick if you analyze the duration of the attacks.
Diagnosis by stopwatch. I love that. Moving on to segment 4, we're getting into the rare, the weird, and the daily. The lectureless headaches triggered by specific activities, like coughing.
Primary cough headache. It's exactly what it sounds like. You cough, strain, or sneeze, and boom, a sudden severe headache. But here's where we have to be careful. Before you call it primary, you must rule out a structural issue called a Chiari malformation.
That's where the brain tissue extends into the spinal canal.
Yes. If the back of the skull is a little too small for the brain, the cerebellar consoles can get pushed down into the neck. When you cough, the pressure spikes and jams that tissue down further, causing pain. So you have to get an MRI. If the MRI is clear, then it's a primary cough headache. And guess what treats it?
Don't tell me. Indomethacin.
Indomethacin. It's the Swiss Army knife of weird headaches.
Then there's the primary exercise or sex headache.
Also called exertional headache. It's triggered by intense physical exertion or sexual activity, specifically at the moment of orgasm. It's sudden, explosive, and frankly terrifying because it mimics a hemorrhage,
That's a mood killer.
to put it mildly. But once we rule out a bleed with imaging, the good news is it can often be prevented by taking medication like indomethacin or beta blockers before the activity.
Hold on, honey, I need my beta blocker.
But better than the alternative. Now, we touched on the thunderclap earlier as a sign of bleeding, but the source says there is a primary thunderclap headache too. Yes, this is a diagnosis of exclusion. You do the CT scan, you do the lumbar puncture, and there is no blood, no aneurysm. But the patient still had that explosive pain. This is often due to something called reversible cerebral vasoconstriction syndrome, or RCVS.
What is that?
The blood vessels in the brain suddenly spasms and clamp down in multiple places. It's scary, and it can cause strokes if it's severe, but unlike a ruptured aneurysm, it typically resolves on its own over a few months.
Now for the curiosities. The lecture mentions primary stabbing headache.
Also known as ice pick headache. It feels exactly like a sudden, single jab with an ice pick. Lasts for 1 or 2 seconds. Totally irregular, it's frightening, but usually harmless.
And the hypnic headache. This one is so specific it's spooky, the alarm clock headache.
This typically affects the elderly. The patient wakes up at the same time every night, say 3:17 a.m. with a headache. It never happens during the day, it's strictly nocturnal. And the treatment is fascinatingly counterintuitive.
Caffeine.
Yes, a cup of strong coffee right before bed often prevents it.
Which makes no sense. Coffee is supposed to keep you awake.
For most people, yes. But for hypnic headache patients, the caffeine affects the adenosine receptors involved in sleep cycles and pain in a different way, allowing them to sleep through the night without the headache waking them up. It's a true paradox.
Okay, we have to talk about a major trap now. The expert in the source material emphasizes this heavily. This feels like the public service announcement portion of the episode. Chronic daily headache and the medication overuse paradox.
This is arguably one of the most important concepts in headache medicine. Medication overuse headache, or MOH, It is a condition created by the attempt to cure it.
Walk us through the mechanism, because the logic seems sound. I have a headache, I take an Excedrin. I have another headache, I take another Excedrin. How does the cure become the disease?
It's a desensitization issue. If you take acute painkillers, NSAIDs, triptans, opioids, or especially caffeine combination drugs, more than 10 or 15 days a month, your brain chemistry shifts. Your body stops making its own natural painkillers because you're flooding it with external ones.
So you're downregulating your own defenses.
Exactly. And the brain becomes hypersensitive. The pain threshold drops. So now, as soon as the Excedrin wears off, the brain panics and triggers a rebound headache.
So you wake up with a headache, take a pill to fix it, which guarantees you'll have a headache tomorrow when it wears off, so you take another pill.
It is a vicious, self-perpetuating cycle. We see patients taking 6, 8, 10 pills a day just to function. And the headache never really goes away. It just dulls slightly. The medication is no longer treating the headache. It is fueling it.
And the solution? Well, it sounds like tough love is an understatement.
It's brutal. The only way out is through. You have to stop the offending medication, usually cold turkey.
And presumably the headache gets much, much worse when you do that.
Much worse. For about a week or two, it'll be agony. It's a withdrawal period. But once you break that cycle and reset the brain's threshold, the chronic daily headache often disappears, and you're back to just having occasional episodic migraines that you can actually treat effectively.
That is a hard sell for a patient in pain. I'm going to take away your medicine and you're going to feel worse before you feel better.
It is. It takes a lot of trust. But it's the only path to a cure. Everything else is just managing the addiction to the relief.
Before we finish, let's look at segment 5, pressure dynamics. This is all about the fluid, the CSF that the brain floats in. Too low or too high? Let's start with low CSF pressure.
Spontaneous intracranial hypotension. This is basically a plumbing leak. There's a hole in the dura, and the spinal fluid is leaking out.
And the clue here is gravity, right? The posture of the patient.
Exactly. We call it the orthostatic headache. When the patient stands up, gravity pulls the remaining fluid down into the spine. The brain loses its buoyancy and literally sags inside the skull, pulling on the pain-sensitive anchor points. The headache is terrible when standing.
But when they lie down,
the headache disappears completely, often within minutes, because the pressure equalizes. If a headache vanishes when you lie flat, you have to think about a CSF leak.
And the fix is incredibly visual, the epidural blood patch.
It's exactly what it sounds like. Doctors take the patient's own blood from their arm and inject it into the space around the spine where they think the leak is. The blood clots and seals the hole like a patch on a tire. The relief is often instant. The brain floats again.
Now the opposite, high CSF pressure, idiopathic intracranial hypertension, or IIH.
This profile is very specific. It typically affects overweight women of childbearing age. The mechanism isn't fully understood, but essentially there is too much fluid pressure inside the skull. The brain is being squeezed.
And this one affects the eyes too, but differently than the giant cell arteritis we talked about.
Right. The pressure pushes on the back of the eyes, the optic nerve head, causing papilledema, which is swelling of the optic disc. If you don't treat it, it can cause permanent vision loss. Patients might have transient vision loss, double vision, or a whooshing sound in their ears that's in time with their pulse.
And the treatment.
Weight loss is actually curative for many. It reduces abdominal pressure and helps regulate the fluid dynamics. But medically, we use a drug called acetazolamide, which basically tells the brain to stop producing so much spinal fluid. We turn down the tap.
It is amazing how mechanical some of these solutions are. Patch the leak, drain the fluid. It really demystifies the brain.
It does. It reminds us that for all its complexity, the brain is still a physical organ subject to physics and hydraulics.
So we've covered a massive amount of ground today. The lecture wraps up by suggesting a grand approach or a diagnostic algorithm based largely on duration. I think this is a great way to summarize everything we've learned.
It is the best way to organize the chaos. If you are trying to figure out what you have, you just need to look at the clock.
Okay, lay it on us.
If the sharp pain lasts for seconds or minutes, think neuralgias like ice pick headache or SUNCT. If the attacks last 15 minutes to 4 hours, that is the realm of cluster headache or paroxysmal hemicrania. If the attacks last 4 hours to 3 days, that is the classic window for migraine or a tension-type headache. And if it is continuous, never stopping, think hemicrania continua or new daily persistent headache.
That is such a clean way to sort it out. The clock doesn't lie.
Exactly. Diagnosis by duration.
So what's the big takeaway here? For me, it's that headaches are a language. The body is trying to tell you something very specific. I heard at night means one thing. I hurt when I cough means another. I hurt when I stand up is totally different.
Absolutely. The biggest mistake you can make is to silence that language with a generic painkiller without understanding the message. Whether it's the timing, the trigger, or what relieves it, like the alcohol trigger for cluster, or the indomethacin relief for hemicrania, these are clues, they're breadcrumbs.
And it brings us back to that provocative thought from the start. We have headaches that are featureless. We have headaches that respond to caffeine. We have headaches that only respond to oxygen. It raises the question, how many people are out there suffering, thinking they just have bad headaches, popping ibuprofen that isn't working, when the actual key to their lock is something totally different?
That is the tragedy and the hope of headache medicine. The difference between a life of agony and a cure might just be realizing you need oxygen instead of triptans, or indomethacin instead of Tylenol. The mechanism matters more than the sensation.
The mechanism matters more than the sensation. I love that. And on that note, we're going to wrap up this deep dive. Listen to your head, watch for the red flags, and don't be afraid to look at the clock. Thanks for listening, and we'll catch you next time.
Stay curious.